This session is related to personalized medicine and healthcare. And what we're going to do is give a comprehensive assessment of where we are as an institution and try to frame that in terms of where the country and the world is going with this. And, so we'll take an inside look, a deep inside look, and we'll go outside and look and see how, at the boundaries we can increase the kind of engagement that we want to have happen to make the experience of healthcare personal, more personal than it is right now. And I should say that listen, I mean, we do a pretty good job at this already. It isn't like we don't treat the patients as individual. They have something called the individual patient care experience. We heard more about that last night when our strategic plan for the health system was unveiled by Dr. Peskovitz at the dinner at the Michigan League. And, but there's something big going on regarding personalized health. There's a convergence of things. And so let me plug in my notebook and introduce our panel more formally. And I will say this right up front, that I do have some engagements with scientific boards. I chair the scientific board of Apistry Corporation, which is a company that does cloud computing in several spaces, including the life sciences. I chair the board for not-for-profit scientific technical board for One Mind for Research, which is a neuroscience, not public-private partnership on the East Coast. And I work on the scientific board of Ascentia Biopharmaceuticals, which is a holding company that has 6 biotech and pharma companies within it. And I have no conflicts of interest with any of the things that I'm going to tell you in those things. So that's, Catherine, the kind of things that we have to do now. And that's coming from the institution and the NIH. Now, is that happening on campus too, guys? I mean, are folks having Marios? Are you having to declare your potential conflicts before you talk? It's coming your way. This is NIH has really been the kind of driver on this. Okay, good. Now, we have really a nice panel put together. And I'm going to limit my time. People have heard me talk for years. And Andrew Rosenberg, who is an associate professor of anesthesiology and, very importantly, our chief medical information officer of our health system, and has incredible responsibility for shepherding the process, which he will describe to you in some detail, of re-engineering our electronic health record system. And you're going to hear a lot about that. And what I will do is make a few brief kind of framing remarks and turn it over to Andrew. And he'll give a talk that he and I and Jocelyn DeWitt, our health hospitals and health centers CIO, and Ted Hans, CIO of the hospital, worked on together and was presented as our strategic vision for the health system information technology, and was actually derivatized into a set of priorities and budgetary allocations to actually make our plan a reality across the 3 missions of research, education, and patient care. And so Andrew will be taking the bulk of the time here today to tell you about that, followed by Professor Larry Ahn, who is with the Department of Internal Medicine and the Comprehensive Cancer Center and the School of Public Health. And he is our expert on engaging patients and populations and individuals and making the healthcare and medical and healthcare experience more personal. And so what I will do is start and turn it over to Andrew and just describe all the things we're doing in our health system now, framing against the national landscape, which has really changed a lot. A couple years ago, there was something called the High-Tech Act. I think how many people have heard of the High-Tech Act? Andrew, that's his assignment. He'll tell you about that. But that mandated certain things that we had to do in terms of implementing electronic health record systems in our inpatient and ambulatory and frankly in the physician's office, and making the United States of America a place where we have electronic health records that are used meaningfully. And that's the law. And that was put into effect in the High-Tech Act as part of the ARA bill that went through Congress a few years back. And so there are incentives to get people to play, but ultimately in 2015 there will be penalties if you don't. And so we're moving towards a tipping point now where in the United States of America, we'll be going digital here in the next few years, and that's needed. Okay, so, already got some issues. I hope it's not going to be big. Okay, it looks better. It's coming up weird on my screen. So that's just us, okay? And we really want to have some question and answers and discussions. We're here to share information with you and to learn from you. This is just the scope of where we are. I think it's important just to set the context. The University of Michigan is a basic medical, biomedical science powerhouse. We are now, you know, actually today, we have the 4th most funding from the National Institutes of Health of any academic medical center in the United States. We bring in some $360 million from NIH in funding for our research. Much of it is basic research, okay? There's the basic research, which is fundamental discoveries, and then there's clinical research, which is, you know, checking things out in the hospital, in the ambulatory care clinics, out into the homes, doing clinical trials, testing hypotheses. The vision that we have for our health system and frankly the country is to move some of the basic research through clinical and translate that out into practice. That's our dream. And you know, our dream is in some ways enabled, but also made more complicated by the emergence of measurements like bioinformatics or things like that that are coming on board real quickly. So the bench to the bedside, out into practice. That's the kind of flow, and we want to see a flow back and forth. So when Larry talks about engaging the community, he's talking about being out there and testing things that are going back and forth. Maybe it's research, but maybe it's actually, you know, delivering the appropriate clinical support and clinical care to our patients. How do we personalize that? So that's the overall scope. And so the University of Michigan views itself as a special place where we have all this basic research going on and special places like the Cancer Center and the Depression Center and the Aging Institute and all this kind of stuff. And then, you know, in clinical research, and then ultimately engagement with the community, both locally and nationally. And we have the CTSA as one of the big programs that we have that's funded by the NIH to help us with that, the Clinical and Translational Sciences Award. This is a slide that shows a picture basically of some of the new ways to think about research. And it's relating the molecular measurements to something that you see in the physiology. So, you know, the relationships between the genes and what happens to you in your organ. You know, do you have a gene or a set of genes for a Mendelian trait or a more complex trait that predisposes you, say, to cardiovascular disease or coronary artery disease or something like that. And so, you know, in the past, you know, we would kind of measure what we call the phenotype, but now we have the ability to kind of do modeling and make measurements from bioinformatics and kind of relate the two. And you know, sometimes even we can add more information in between. We can look at genetics and perturbations of genetics, and then look at, you know, how that turns into proteins and metabolites and relates to the physiology, cellular physiology, and, you know, relates ultimately to a condition. And then we could look at things like environmental practices, smoking, nutrition, things like that. Genotype to phenotype. You know, a lot of basic science here, but a lot of now basic science done in the clinical departments and in the practices, you know, as we try to understand this better. You know, and you're thinking about it a little deeper, and you'll see this in Andrew's talk. I think you'll see it again. You know, and I think some of you saw Gonçalo Abacasis's talk and Jim Cavicoli yesterday. You know, the world of bioinformatics, where we're measuring the whole genome of individuals. Or, you know, the most exciting thing that I heard yesterday from Gonçalo was that his paper in Nature of the 1,000 genome projects. And he shared with us, you know, and they've analyzed 374 of the 1,000 genomes for that publication. It's the most highly cited publication of any biomedical research publication in the world came out of this place this last year, the 1,000 Genomes Project. So back in 2001, the genome was sequenced at the low, low price of about $3 billion. And now we're looking at a $2,000 per genome. And Gonzalo mentioned yesterday in his talk that he hopes in the next couple of years we'll be analyzing 20,000 human genomes. Here, on site at the University of Michigan, is ramping up to our DNA biolibrary program where we're anticipating taking 100,000 specimens, keeping the DNA, and linking in the data from the electronic health record, and Andrew will describe that to you. So, there's all kinds of measurements right up the stack. One of the strategic planks of our health system research strategic plan is getting more involved in metabolomic studies and obesity. I think we all know that's a big problem in this country and in the world, but it's nature and nurture, huh? It's not just what we can find out from, the bioinformatics. There's lifestyle issues. I think Larry is going to deal with some of this kind of stuff. So going from the genotype right straight up to the phenotype, the organ, that heart that we saw, the tissues within the organ, like in the kidney, different tissues, and so on. It's all right there. And so, one of the things is, and I've only got 2 slides, I'm going to turn it right over to Andrew, is clinical decision support. One of the big 3, going fully electronic in the electronic health record, getting clinical decision support to work just right, and increasing the fidelity and the usability of the interfaces that give us access to the information. These are kind of the big 3 issues that are on the, big horizon for clinical and health informatics. And, the simple idea here is, gee, you can only keep track of about 5 ideas in your head at once. So what happens when we have all these other measurements coming up? You need a computer. Whether it's to code the bill with the ICD codes, you need a computer. Whether it's to make a decision based on measurements that will be making in the lab, you need a computer. You need information management. You need to put it all together that way at enterprise scale. And so just my last slide is to show you, well, I had a nice talk with this wonderful fellow, Gianrico Farrugia, MD, at the Mayo Clinic in Rochester. And here's his plan, a $350 million 5-year plan to implement personalized medicine at the Mayo Clinic. These are the topic areas. Clinomics. Well, remember that stack? He made up a new word to describe that whole stack I just showed you. They call it clinomics over there at Mayo, just so you know. Epigenomics. It's not just the genes, but it's modifying those genes or even the proteins that are involved with those genes. And actually, there's some kind of heritability that goes on with that as well. And we have to keep track of it. Pharmacogenomics, big subject. For example, in our psychiatric clinics, we can make measurements of how people metabolize certain, say, SSRI compounds, antidepressants, because some people really metabolize them, some people don't metabolize them so well. So if you're going to treat, if you could measure individually, you can increase the treatment effectiveness. The microbiome. It's kind of like the talk we saw this morning about the ocean floor. We have 1 trillion cells that make up our body, but we have 100 trillion microbes that make up our body. 100 times more microbes are in your body as cells than the cells we have in our body. In the microbes that are here, kind of in the little nape of the elbow, are different than in here. And actually, the microbes that are in between each and every one of your teeth are different and we're starting to measure all that right now. And it's one of the big areas of medicine and infectious disease. And biomarkers. Gee, if we really want to understand how somebody personally kind of presents themselves against this molecular way of thinking, we can make a measurement, and oftentimes that measurement is called a biomarker. So that's Mayo's plan. We're implementing something very similar to here. I'm turning it over to Andrew so he can tell you what we're doing. And thank you.
This is working out good, so I can move around. Well, as we're getting set up, thanks, Larry, and thanks, Brian. My name is Andrew Rosenberg. I'm, as Brian said, I'm the Chief Medical Information Officer for the health system. And that's actually a relatively new position. We've had a CMIO of the hospital, but not really of the health system. And one of the reasons why that's important is the reason why you're here. The reach out to a variety of other areas now is really like no other. And living in a silo of just clinical care or academic or research care is very passé. And cyber infrastructure, like many things, is really a foundational tool that simply, those kinds of outreaches are not capable without this kind of work and this kind of infrastructure as well. I also need to apologize that I'm in my scrubs. I was in the OR briefly this morning. Normally I would not be in my scrubs for something like this, but I just simply didn't have time to change before I came here. We're in the hospital, that's never an issue, but I apologize for that. So I am going to, hopefully this clicker will work because I tend to like to walk around while I talk, but we'll see, and if it doesn't, no problem. I am going to go through a variety of, an overview of the lay of the land from an informatics point of view, but as much lay of the land from the health care and the trends in healthcare right now, because I think that to understand what we're trying to do, you need to understand several of the problems. So what I will be discussing is actually this very small portion of what we now like to call the Athey puck diagram, as he and Frank Mannion and others helped put this together. But we're talking about an enormously complex, multi-$100 million informatics infrastructure system on the clinical side now. And that's just one very small part of a much, much broader and much more complex system. Fundamental to clinical, operational hospital informatics versus academic informatics is sort of the tension between the standard, highly standardized, structured command and control of implementing systems in super high critical areas where redundancies are necessary. Think about airplanes, think about nuclear reactors, think about operating rooms and ICUs where literally downtime could cost lives, versus the much more nuanced, participatory, innovative, highly fast-paced need for informatics around discovery. And when you start to blend the culture of the hospital with the culture of the lab, you come up with that tension, which is a perfectly legitimate and fine tension. But when we now start to talk about standardized cyber infrastructure, when we talk about informatics, that is one of the things that we have to come to agreement on. And it's really a fascinating thing that we're watching evolve almost week by week now, of cultures starting to come together. And I think what's helpful is also having a research background, and frankly, many of us do both of those things. So I'm sorry, I need to go forward. So briefly, I want to tell you about our health system and our health care. The University of Michigan is not just a really big hospital, or as of this weekend, another new huge hospital opening up. If you don't know, the Children's Hospital is opening up this weekend. We have an enormously complex and large and active medical school. We have a university health service, which, by the way, will also be going to the same electronic systems that we're talking about in the hospital. We have a school of dentistry, a school of public health, all of which are involved in much of what I'm going to be discussing. But then, even around the institution, we have many other sites that are actually participating in health care that you would normally not think of, but are both clinical health care, psychological clinics, social work clinics, even the athletic department apparently has its own sort of health care that's somewhat separate from others as well. But they're also involved in academic work, in investigation, and in teaching. I will get it. Normally I'm able to just advance here. So there are a few trends in medicine that are fundamentally shifting the lay of the land right now, and here are a few of them. Number one, the percentage of US population, seen here as the total number of people in millions on the y-axis, in years on the x-axis, who are older than 65, has reached an inflection point as the baby boomers now start to get into retirement. We are having an aging population at a rate of aging that the US has never seen before. And the implications on many things, including health, are going to be profound. And if you've heard or read in the paper that more medical schools are being built in Michigan alone, there are 3 new medical schools that are now operating in the last year and a half. 3 additional medical schools. It's actually in anticipation of the increasing need of healthcare because of that. Similarly, we actually have a decrease in the rate of births in the United States. So somewhat like Japan, already we are now entering into a US population that is older. Now that's important because as people get older, they acquire more diseases, and chronic diseases start to get worse and worse over time. And yet, when you just throw huge amounts of resources like we have had in the United States, we actually tend to modify some of those diseases. Here, the death rate for cardiovascular disease, heart disease, coronary heart disease, congestive heart diseases, and stroke have all been decreasing. And that's one of the major chronic disease burdens of the elderly. As you get older, people over 65, about 1% to 2% of people older than 65 have congestive heart failure. As that population rises, their burden gets greater. So when you throw a lot of money at it, you tend to actually make the outcomes somewhat better overall. But it's incredibly expensive, and what you then might say is, well, how expensive is that? Well, right now, we have about 130 million Americans who have some form of chronic disease. That accounts for about 70% of all the deaths, and it accounts for about 75% of our $2 trillion healthcare. So it is enormously expensive to deal with chronic diseases. And so because we spend so much money, we should be doing really, really well on outcomes and efficiencies. And not only are we not doing average, we're actually doing much worse than average. On the y-axis here, this is life expectancy as a general proxy and marker for the overall efficiency of a country's healthcare system. And on the x-axis is the amount of money per capita spent on that, on an individual. In general, you can see here, westernized countries are deviating around a certain average. And here we are, the United States is an enormous outlier to every single westernized country. So we spend we spend about 2 times as much per capita, and yet we actually have not even average outcomes relative to other countries. And that is a major driver of a lot of policy towards what we need to do, including policies around informatics as well. We also have an issue around medical errors, which hopefully you've read and heard about, because it's really only received attention for the last 10 to maybe 15 years at the most. Now these errors have been occurring all along, but really they've only been getting attention somewhat recently. They're about the 4th or 5th leading cause of death in the United States. Now, to be very fair, that's actually not correct. So here's an example of what would be constituted as a medical error. I, up until yesterday, ran the ICU at the CVC as the director of critical care. And you'd have a patient who is critically ill and really dying. And they would get an extra dose of a medication that didn't kill them or add to end organ injury, but we would call it out as a medication error. Well, that does fit into that rate of about 99,000 medical errors per year. So I want to put it into some perspective. That said, it's just completely unacceptable to have errors. In the airline industry, they don't say, well, we're going to have 2 or 3 airplanes crash every month. But the statistic is about a 747 a day, I believe. So the order of magnitude is still pretty impressive. So because of the trends in healthcare, the trends of the aging population, the disease, the expenses that the United States goes through, and yet outcomes don't even come close to matching it, there are all sorts of movements to try to improve that. And one of them is around the delivery of care to improve quality, accountability, but also to try to change the funding mechanisms for what is still currently by far the most expensive healthcare in the world, by far. And at its core are among ideas of this idea of the medical home, an accountable care organization, or some form of integrated health system that says, you don't just come here and we do a procedure on you and you leave. We're now responsible for your care. We're responsible to make you healthy when you're sick, to keep you from getting sick. And Larry will talk a little bit about some of those kinds of things as well. But we are responsible, and shifting the idea of, please come here and we can do more stuff and get a lot more money, to we take some risk. And that's this concept of the medical home and accountable care organization with an idea that a patient has a group of sequential layers of care, from a doctor or a clinician to a system, to a broader system to take care of primary preventive care or specialized care. And you'll hear these terms around accountable care organizations. Whether that takes off or some form of it, that's really where the country is moving. Now, everything I've mentioned isn't even remotely new. And here's just a great quote that I think spells out a great deal of why today is so interestingly important. One of our great clinicians said, "I am fain to sum up with an urgent appeal for adopting some uniform system of publishing the statistical records of hospitals, clinics, primary care providers, substitute whatever you want. There is a growing conviction that in all hospitals, even those in which are best conducted, there is a great and unnecessary waste of life. In attempting to arrive at the truth, I have applied everywhere for information, but in scarcely an instance have I been able to obtain hospital records fit for any purposes of comparison. If wisely used, these improved statistics would tell us more of the relative value of particular operations and modes of treatment than we have means of ascertaining at the present." I mean, keywords just seem to lift out of that slide of everything that in the medical side, comparative effectiveness, information versus data, comparing to one another, of all of these kinds of things are exactly what we are doing right now, and you'll see in just a minute why these are so important. And these were said way over 150 years ago by Florence Nightingale. So there is nothing new, even remotely, about what we're doing right now. This is not even in the same ballpark as new. But there is an enormous revolution happening because it's actually starting to happen. Her needs at the time could not be done. Even if people were all on board, they didn't have the information systems to do it. And now we do. So what's happening to do that? Well, one of them is to adopt electronic medical records. And where are we in the United States? Well, we are really not there. This is around right now. It's a little bit old, but it's still relatively new, the year 2010. And this is the percent of, sorry, this doesn't seem to be picking up. The percent of physicians who, in their ambulatory clinic offices, have an electronic medical record, and it's about 50% at best have anything. That even includes just a schedule or record-keeping system. And about maybe 11 to 12% have something that you would want, which is a fully integrated electronic healthcare record in ambulatory care. So if you go see your private doctor in their clinic or a nurse practitioner, chances are, flip a coin, they'll still be working on paper today, like Florence Nightingale lamented in 1863. How about in the hospitals? This is a measure of the sophistication of highly integrated electronic systems from 0 to 7, 7 being the most integrated. I write an order. If you don't get it done, you get a reminder, I get a reminder. There's a portal that you could log on to, all sorts of integration of documentation, clinical decision support, the things that you would want us to be doing. And about 1% of US hospitals are there right now. 1%. And way over 50% of the hospitals are essentially still using transactional systems that were really the only thing available in the late 80s and early 90s. So from the ambulatory care side, from the hospital side, at best, we're maybe about 50%. But that's changing very, very quickly. One of the reasons it's changing is that those places that have those sophisticated systems are demonstrating much better outcomes. One of them is the ability to do orders in an electronic system. You can read the orders. You can be reminded about the orders. The data can come back to multiple people because it's all digital as opposed to on paper. And here's an example of using what's called CPOE, Computer Provider Order Entry, and to use some basic forms of decision support. Hey, you just wrote to give me 1,000 milligrams of morphine when you really should have just given me 10. 100-time overdose. In fact, when we went up on our CPOE system at Michigan, one of the errors that occurred was that someone wrote for 100 milligrams of lorazepam, which is a sedative. And it was only detected because the nurse who was trying to take the dozens of vials out of the system to draw up 100 milligrams realized there is something wrong here with that order. You would think that had been brought up. But again, those things still happen. We talk about 10x errors, you know, that extra zero. And that goes from what you should get to what could kill you. Now, we have multiple redundant systems to avoid it, but those things should just never, ever happen. They should be engineered out. You, I would imagine, might say, well, why could they even write that 1,000? Right? Because that's what I would say. Why even allow for that kind of medication to even have it there? And those are the kinds of things that over time start to just get engineered out. You simply can't even write for an overdose. So when you do that kind of alerting, you can see the number of orders where there is a problem, where you've exceeded a maximum dose, goes down significantly and then sustains itself. Because really, you're having a computer, as Brian so properly said, we're having information overload. You shouldn't expect me to try to remember that for the hundreds of orders I and clinicians write a day. You want the system to take care of that. An airplane can't go forward if its flaps are deployed for landing. It just won't happen. And that's because airplanes crashed when they tried to take off with their flaps up in the landing position. They just engineered that out. And we're still in the process in electronic records doing that. Yet, it still can happen. Here's an example in our own institution where a patient had 1, 2, 3, 4, 5 potent opiates, all active orders running at once. And we've done that on paper all the time. And the reason we sometimes do it is, I don't know what you're going to need, so I'm going to write 5 different medications, or I'm going to try one. If that doesn't work, I'll write another. I'll forget to DC or discontinue the previous one. And then a really good nurse will be able to say, well, oxycodone worked better than the fentanyl patch. I'll try that right now, and you get good pain relief. The downside, of course, is you could start getting 5 different narcotics, and you fall asleep on the floor, and you die. And that has happened. And what we've done now, have engineered it, so that simply can't happen now. This is a slide from 4 years ago. That can't physically be done right now. We've engineered, if you write for one of those types of opiates, and you want to change it, that becomes inactive. We've engineered those away. But we're still having to kind of do that individually. We don't have these real great broad standards of how to do that. I'm trying to show you this as much to give you ideas of some of the problems we face, because perhaps you might want to work on some of those solutions. So part of what I'm trying to do is to give you some of that insight as well. Okay, so Brian talked about high tech. What is happening now that didn't happen 10 years ago is there's now money, big money, behind going to electronic medical records. And it really came out of the American Recovery and Reinvestment Act, that $750 billion to try to help the economy in 2007, 2008. And within that bill was about $29 billion, $29 billion to incentivize us, US healthcare, to adopt modern, certified electronic medical records. Not homegrown, custom things that I developed on my own and that we plug into the network and try to work it out like we've been doing for the last 20 years, but now truly modern, certified, standardized approaches. The Office of the National Coordinator, which is a part of Health and Human Services, sets out the standards for what constitutes a modern electronic healthcare record, the things that it should be able to do, like that ordering system that I mentioned. And it's tied by this act to the money to CMS to pay if you do those things. For example, our health system could get about $60 million if we do this properly, and will be penalized over $100 million in the next 8 to 10 years if we don't do this. Turns out we actually already are fully electronic and have been, but we've been doing it through a lot of customized systems that are all attached together. We have to do all of this in a very fast phase, although the stage 2 meaningful use literally yesterday got pushed back to 214, so I didn't even have time to change my slide, but we have to be doing this over the next 5 to 6 years. And just as a list of some of these ideas, what we're talking about with these systems, electronic orders, checking allergies with drugs, being able to prescribe medications electronically, having your problems and issues in structured text so that you can write rules to that. It can be populating registries. It can match up to the genomic, metabolomic, metabolic data, things like that, so that other consumers can use these data now in much more innovative ways. Among the problems is that one of the things we have to do is to be able to talk. University of Michigan has to be able to talk to St. Joseph's Hospital seamlessly. Well, they're our competition. and so's Cleveland Clinic, and so's Western Michigan. We don't want to talk to them because they're our competition. We want the cases. We want the revenue. Of course, that's an exaggeration and a cynical view, but it's not entirely wrong. And yet, from the patient's perspective, from your perspective, from my perspective as a patient or consumer, I don't want you to not be able to talk to each other. I want you guys to know exactly what happened here to happen there. And so the infrastructure, the networking to have that, and the standards around what the data have to look like and how they transmit are being worked out and are part of those expectations from the Office of the National Coordinator. So although we can build our electronic system, part of what we have to do now is to attach ourselves to a network, much like the interstate system in the 60s was for transportation. We have to develop incredibly detailed and robust reports at the individual practitioner level of things that I do versus Larry does versus others do. We get evaluated on it. We can be the change management and try to change our behaviors in these sorts of ways. And yet we have to do this, and why we're talking to you and why Brian, ourselves, others all work together, is that we really have to do this within the context of we are a fundamentally academic, research-oriented health system. We are not a standalone clinic. We are integrated deeply with the academic environment in the University of Michigan, and not just the health system academic, but as a university. And so the complexities of prioritization, resources, infrastructure to do all of this kind of work are part of the challenge of doing this at the same time. So let me finish with this. This is what we're doing at the health system. This is a highly simplified view of our electronic environment on the clinical side. We have more than 500 separate applications, all that have to talk to each other, all that feed into common clinical data repositories. This system here, our revenue system, is a mainframe computer that uses COBOL. We can't find people to even update it anymore. I mean, it's COBOL, right? Okay. But that's where over
there's good news coming up on that.
yeah, that's where over $2 billion of revenue flows through that system that's based on a COBOL mainframe. Where we're moving to is this, a much, much more unified system using a software from Epic Corporation out of Madison, Wisconsin, that is a modern electronic medical record. And that's going to take us about 8 years if we're lucky. Right now, we're about to change out our entire business systems in February, entire scheduling, registration, and billing systems. So that COBOL, that's going away. And then we start to go to the ED, and the entire ambulatory clinics go live with the new system in August. And then we go to inpatient, ORs, and specialty areas as well. But we also have to be doing other things. We have to be attending to other needs that we have. For example, the age of thinking about what telemedicine could look like in 1924. And just as an aside, because Brian's here, I showed this at a talk the other day, Brian. I've been using the slide for about 1.5 years now. Brian saw the slide, and in my office shows up a hard copy of this journal that Brian Athey found for me at a flea market. So I have this actual journal. But one thing that came out of it was... We learned something is, so this looks like telemedicine, that's pretty cool. This is a prescription getting printed out. So it's not just telemedicine, it's e-prescribing all being envisioned in 1924. Well, we're there right now. The ability to do telemedicine, remote care. I've actually done critical care via monitors through EICUs. We're actually up and able to do those things right now. But we also, as Brian said, we have to be linking these phenotypic outcome quality data to all of that innovative, highly non-standardized, difficult to get, and did you see the New York Times this morning about DNA sequencing in China? That the rate-limiting step now is going to be networking and bandwidth to transmit these enormous amounts of data. Well, we have to be doing all of that work at the same time. And when you look at what seems to be a relatively simple healthcare system, clinical, to data warehouses for research purposes, it rapidly becomes very, very complex. And then finally, I'll end with this, is that although I've been talking about this line, this line, and this line, and this line, we have all of these other projects coming down the road. Boom, 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 boom. We're in a phase of transformation that is simply orders of magnitude different than we've ever had in our healthcare system at Michigan, but this is also true around the country. And the main driver of this is that slide I showed you about the incentive and the penalty money. There's also billing issues, ICD-10 that has to change. And so we're going to be going through an enormous amount of fundamental change for the next 5 to 10 years that is truly revolutionary, which means also there are enormous opportunities for investigation, study, and innovation along the way. So that was a whirlwind overview, but I hope that was helpful to you all. Larry?
Thank you, Andrew.
Thank you. Do you need this?
I'm just going to be up here, so I probably won't. Thank you. Is that gonna work? Great. So my name's Larry. I'm the director here for the Center for Health Communications Research. So we spend our time thinking about how do we put together messages that are meaningful for patients. And so Brian showed we'll call it the omics sandwich, so to speak, sandwich slide. And Andrew talked about the amazing changes that are happening in terms of healthcare systems. And what we think about is, what are the challenges in terms of communicating around these issues? What are those communication challenges in this new omic era for patients? How are we going to communicate results of these new tests to patients? Will the public or patients understand the information they're getting? How will the new information be used to actually influence treatment decision-making? And how will this new information influence important health behaviors and lifestyle choices that people make? So this is what we spend our time sort of thinking about. And shall I say, with all the changes happening in the information landscape, we have a lot to think about. You could say, well, the omic era is already here, right? Who's heard of 23andMe or seen those sites? So I just went on their site. You can, for a couple $100, get your DNA sequenced, and they will provide you a report that gives you your risk, your own risk compared to the average risk of, I think it was up to 250 or so health conditions right now. Now, we can talk a lot about, so what do people actually do with this information is understandable, and we can drill down into some of those issues. But all is to say, the omic-ish era probably has already started, and many corporations and businesses aren't going to wait for us to get it right, so to speak. But it's really important to sort of understand what is going on in this field. The way that we approach it is with the notion of tailoring or personalization of information as well as all the other aspects of care. So when we talk about tailoring, we talk about a process that involves assessment of individual characteristics and behaviors, algorithms that are use that data to generate important and relevant messages for people, and then to provide that in a clear and vivid format. And so how this would be implemented, for example, is that we would have a message library with a range of different messages for people with different sorts of demographic characteristics, readiness to change, or different attitudes about benefits or barriers to change, or different sorts of plans that might work for an individual. We would do assessments to understand for that specific individual what are the characteristics that are relevant for them, and then we would stitch together what we call a tailored message where all this comes together for that specific individual. We can talk about that at some length later if you want about how we actually do that. But where it's most relevant here relative to this omic area is how is health communications going to interact or work in an area of personalized medicine? And so what I wanted to do is just talk about a couple important topic areas and show some of the work we've been doing in each of those areas that I think you might want to think about or we could think about in terms of sort of approaching these areas. And the areas are health literacy, numeracy, the understanding of numbers, clinical decision support that Andrew and Brian both mentioned, the concept of shared decision making and the involvement of patients in making decisions, something I'll call conversational support because as Brian is fine, I don't know, sometimes this happens when my wife and I are trying to schedule the week, right? You can only keep 5 things in your head at each time, but we have about 30 things. So how do you create an environment where people can have productive conversations? And we're trying to create some digital environments where people can have those kind of conversations, and we can talk about that. Yep. And we can look at that. And then the other, which is really important, as we start to learn more and more about people's biology, how do we support their autonomy and decision-making so that fatalism doesn't develop in terms of their approach to diseases and conditions? So those are just some highlight areas that I guess I picked to talk to you all about here today. So first, in terms of health literacy, I think is that a term that's familiar to people in the audience or no? So there's the general, notion of literacy, can people read? And then is, can they read and understand information about health? And at a population level, what you'll know is about 40% of the US population has some problem with health literacy, where they'll need help understanding medical instructions, pill instructions, or ask for somebody to help them read the information they get from the clinic or the pharmacy. What we've done to start to, a project we've done where we're trying to help in this area is around the issue of a biorepository, DNA biolibrary consent process. This is a major initiative at the health system. I think the first informed consent for giving your DNA into the biolibrary was about 20 pages long that people were being asked to read and understand. And what we've done, actually Blake Russler and Nick Stenek have done, is they've worked with the IRB and we've worked with them around the notion of reframing a biorepository project as a biolibrary project. It's really a concept which we think people understand a little bit better, the notion that there is a DNA repository, but really thinking of it as a library, that people enter their books into the library, that researchers are able to check out the books and read it and learn things about health. And then we've tried to develop, using plain language, a simple pamphlet and a one-page informed consent, which we think will dramatically improve our ability to actually develop this resource for the institution. And of course, another approach to dealing with health literacy issues is not to rely on the written word. And this is a project we did with Christine Joseph at Henry Ford Health System. The target population was actually inner-city youth with asthma, and we were trying to put together a program that helped them manage their asthma better. And this is an example of part of the information we put together in that program, which was, did a randomized trial, found to be incredibly successful, and now we're in the process of disseminating to various states in the United States, including a couple of programs right now in rural Georgia and the South. Let's see if this plays.
It's your favorite Puff City DJ, Puff Man!
Are you trying to do this all on your own?
This is what makes up dust. Bam!
Many of professional athletes have asthma. They've learned to keep their asthma under control.
I bet you wish you had that money you spend on cigarettes.
For real.
Are you packing your rescue inhaler?
And I don't have anywhere to put it.
Is it that big? As long as you're packing that inhaler, you can roll with the big dog. Puff Man out.
So that's just an example of some of the work we put together. That was about 30 seconds, and if you paid attention along the way, we packed in many of the important things about the etiology of asthma, causative factors, management factors, and sort of motivational factors for wanting to manage your asthma better. And these are things that we try to integrate into all of our programs that we develop.
Larry, I just wanted to say, when Dr. Emanuel and others went through with high-tech and the administration and tried to see where we could get the biggest bang for the buck, it was a lot of this kind of stuff. You know, this is where the big money is being spent on these chronic diseases. You know, in informing folks and getting people engaged in their health care has got to be the biggest part of the solution for chronic disease.
We think there's a lot of challenges and opportunities. That's probably the best way to say it. We definitely think there is. There's definitely a lot to be gained.
Yeah.
I want to introduce the concept of numeracy to you here. I don't know, are people familiar with that term at all? So it's basically the notion is, do people understand numbers? And if you think about the types of conversations we have in healthcare, it's vitally important that people understand what we're talking about when we say they have this percent or that percent benefit from this disease, or this percent risk of a serious consequence. And what we find, unfortunately, is large portions of the US population, 30, 40%, also will have a lot of difficulty understanding basic numbers, being able to say, you know, is a 1 in 10 chance of something bigger than a 1 in 100 chance of having something? And so we have a group here, it's led by Angie Fagerlund now and Brian Zygmunt Fisher, that works very hard at trying to understand what's the best way to try to communicate information about numbers to individuals. And so they've done a lot of work in terms of looking at different graphical formats for doing that. Bar graphs that would show what is the decreased risk of needing surgery related to taking a medication, or what is the risk of certain side effects. They've looked at using bar graphs, pie charts, something called clock graphs, which are pie charts with values labeled, something called pictographs, which is the graph represents 100 individuals and shows what happens to those individuals, both in terms of the reduced risk of problems and increased risk of potential side effects. And they look at something called gist and verbatim knowledge. Gist knowledge is what you expect. Do they get the general point? And verbatim knowledge, do they understand the specific numbers? And what they found overall is that the pictograph format, the one with the multiple boxes, seems to be the most effective strategy in terms of communicating around both gist and verbatim knowledge. And that's vitally important as we design these clinical decision support tools and patient information materials to really do it in a way that people understand the information that they're getting. You know, we've also looked at how to present information about risk. The tendency really is to present information about the total risk. They would say, okay, so if you're a woman, you're considering whether or not to take tamoxifen after being treated initially for breast cancer, the risk of cataracts developing is 2.9%. Okay? But really, that's the total risk for women taking that. What's the incremental risk? What's actually the added risk that comes from taking tamoxifen? And it's really much more important to highlight that incremental risk than to talk about the total risk. And so this is the approach that Angie developed, and that shows that, you know, cataracts make it hard for women to see, so you have to explain it. Among 100 women your age who take tamoxifen, you know, the additional risk is not 2.9%, but 0.4%. In terms of the absolute risk of developing cataracts. So it's really pulling out the difference between total and incremental risk is a really important approach in communication. The last point I want to make about communication is less more. And here's an example of typical feedback both clinicians and patients might see when they're trying to make decisions about should I have chemotherapy after I've had surgery for breast cancer, right? So this is a program, Adjuvant Online. It ties into epidemiologic databases and shows people information about, you know, of 100 women, how many will be alive, how many will be dead from something other than cancer, how many will die with some other cancer. So it's how many will be alive in 10 years, how many will die because of the cancer, and how many will die due to some other cause. And what you see here is if you have no therapy, hormonal therapy, chemotherapy, or combined therapy. And this is the standard format that you see. The problem with this format is most of the time women don't have to choose between 4 options. Usually, if it's a receptor positive tumor, they're already on hormonal therapy. So you don't need to have that as a separate choice, so to speak. The really choice is coming down to them. Is it chemotherapy or no chemotherapy? And so if you do something so simple as present, you know, the original format, here's your 4 options and choices, versus a simple format of here's the 2 options that we think is most relevant to you. And what they see there in that little yellow bar, that's the incremental benefit of chemotherapy. And I think they can see that here, but it's kind of hard. Oops, it's going the wrong way. It's kind of hard to find the right bar here to look at, if you know what I mean. So this information, and then if you present it using a pictograph format, it's those 2 yellow boxes there right next to the red. That's the incremental benefit of chemotherapy. And what you find is, maybe not surprisingly, that women's understanding of both gist and verbatim knowledge is much improved when you focus on the choice that's most relevant for them. And this is going to seems simple, but vitally important when we think about how we're going to implement these sorts of decision support tools.
How we're going to just inform folks of their choices and taking that omic sandwich and putting it into something like
Right.
this. Larry, watch. Got a lot of work to do.
Yeah, so I want to jump now just a little bit into the area of clinical decision support. And it's really interesting because as we started to dabble into this project is Jeremy Sussman's project. He works at the VA and is in general medicine. It's a notion of, you know, there's guidelines for treating hypertension, there's guidelines for treating cholesterol, there's guidelines about when to take aspirin, but and those are going to be modified by sort of clinical factors and eventually omic factors. But what are you actually trying to treat, right? What you're actually trying to do is you're trying to treat cardiovascular disease. So what if instead of treating each measurable condition one at a time with its own set of rules, we combined all those rules and tried to reduce somebody's risk of cardiovascular disease? And this is where the slide that Brian showed showing how many factors can a person keep in their mind at the same time becomes really relevant. And so what we've done in this tool, it's in prototyping stages right now, is we've built a tool that takes into account their clinical risk factors, the current medications they're on, and makes a personalized recommendation about what sort of medication changes are going to optimally reduce this person's risk of cardiovascular disease, right? And what we've shown, and from his modeling work's done, that if you implement a personalized approach like this that really is trying to reduce the risk of the end condition rather than manage all of the most easily measurable and modifiable risk factors, we can double our efficiency of treatment. And that means we can get the same amount of overall benefit with half the number of prescriptions, or we can prescribe the same number of medications and double the population benefit and individual benefit of our approaches. So this is just an example of some preliminary work we're doing in the area of clinical decision support, tailoring, and personalization. And right now, there's no omic factors in this equation, but I think as they are identified, they just become additional elements of these equations. And that's why I share it with you here. And then people can do drill downs and get specific benefits, all that good stuff about how do you actually present risk. We try to adhere to that as well in these tools. Let's talk about shared decision making for a moment, because many times, you know, it's the clinician who will decide and make a recommendation, but many times it's a decision where there's not a clear right or wrong answer, and we want to try to understand how do we help educate patients to participate in that kind of decision. This is an example of a site we did with Sophia Mariver and Scott Roberts. The goal was to develop a site for women who were coming in to the... All right. I'm not distracted. I really do want to be here. I'm joking. My calendar just drives me along every day. Okay, here we go. All right, so the population was women coming to the breast and ovarian cancer clinic, and what we did is built an interactive experience, originally on computers, now web-based, to help them learn about the basics of breast cancer genetics and whether or not they would proceed on to get screening for additional genetic risk factors for breast cancer. So there was a large component of it that had to do with basically helping people understand what is DNA, how is that related to their risk, that I thought was really important as well. What we're also finding is that I think these omic factors will be really interesting, but how do we put them in context for patients relative to the other things that are important to them? And this is an example where we try to address the issue of preferences and trade-offs. We don't have omic factors in this project per se, but I wanted to share this as a methodology approach to thinking about how to approach this issue. And so it's really the point that if we want to provide personalized patient-centered care, we want to provide care that's respectful and responsive to individual patient preferences, needs, and values, and that those are considered when making treatment decisions. The challenge is, of course, that it's very hard for people to assess or identify their preferences. If you ask people what's important to them, they will say a lot of things are important to them, and the thing that's very hard, who has teenagers? Teenagers, anyone? Very hard to have a teenager prioritize of those things, all of which are vital to them and their existence, which ones are the most important. But those are the things that people have to do in terms of making treatment decisions. And so what we've done is we've adapted a methodology from market research called conjoint analysis. And this is a method that's been used that when people are developing cars or soda or food products to try to understand what are the characteristics of products that people value. This would be an example of very simplistic conjoint analysis around auto design. You know, how important is color? How about size or style? How about mileage? If you ask people these questions directly, maybe they've been trained to learn to say that mileage is important to them, and they will say mileage is important to them. And then you'll go design a high mileage sedan. But if you give people actually discrete choices where you offer them different combinations of these things, what you find is they actually choose the red SUV. And by giving people a series of these choices, you can actually elicit from them their actual preferences. And what we've done is developed or used that sort of methodology around the prostate cancer decision aid, where we try to give basic information about prostate cancer, help them understand what the disease is, make sure they understand some of the basics in terms of the risks of death from prostate cancer. And then we go through a sort of a conjoint analysis exercise where they will tell us through their hypothetical choices whether it's really important to get the cancer out of their body. How important is sexual dysfunction? How important is urinary incontinence or bowel problems or the likelihood and length of treatment of recovery. So these are things that we elicit from them, and they'll create a personalized list through choosing these hypothetical scenarios of what their values might be. And then we use that to help guide a conversation with them about treatment choices. Last one is a project we're doing with Michelle Heisler. Then I'll stop because I'm sort of short on time. A project with Michelle Heisler. This is actually an effort to disseminate AHRQ's consumer guidelines around diabetes medications to underserved populations. This is a project, it's happening with the community clinic in Detroit, the Chaz Clinic. And what we're trying to do here is to create an iPad application where people can go, and it's going to be personalized or tailored and help give them sort of the background information that they need to have an informed conversation about diabetes and medication choices. So just the things to point out in terms of design, which we think is really important. We design it separately for and are sensitive to race and ethnicity. We build in many cultural factors into design. An individual's session would be populated with their own clinical information. There's interactive exercises where they can show how their choices around diabetes control influences their risk of complications from diabetes. And then we put together stories of characters like them that are facing similar issues for them to read and go over together. In the interest of time, I'm going to stop there. We also do some autonomy support work trying to understand how do we better support patients' sense of free will as they're learning information about their DNA, which I think is a really critical and important area. Okay, so just really quick, you know, based on your, what if you got the message, based on your DNA, you have a 30% chance of developing diabetes. People go down different paths when they get that information. Some people say, well, I really need to exercise and eat better. Other people say, well, I guess there really isn't that much that I can do. And so what we've started to do in our work is to understand what is it that influences people's approach to this type of information, and how can we build and support people's autonomy in their decision making. This work is being done by Ken Resnickow in the School of Public Health. It's based on a specific theory in health behavior called self-determination theory, which argues that people have essential needs for feeling of competence, autonomy, and relatedness to others, and how do we support that? And it leads us to develop these alternative types of advice or messages called push or pull, where push messages are ones that basically are telling people what they should do or how they should do things, whereas pull messages are trying to help them generate or come up with these types of things on their own. And in some early work around nutrition and fruit and vegetable intake, we can show that if we present information to people with a high need for autonomy in an autonomy-supported fashion, they will actually be more likely to increase their fruit and vegetable intake than others. So that's just a quick overview of some of the communication challenges that we see in the sort of new era of personalized medicine and some of our early work to try to address those areas. So.
Thanks, Larry. Why don't you just stay
Stay up there?
Yeah, we're going to have some questions. Oh, yeah. She wants me to grab this mic.
Okay.
And then you can stay up there. Yeah, a couple things. So, you know, just doing the gap analysis. Yeah, okay. Let's see. One of the things that we didn't talk about, and it wasn't in Andrew's slide, and you know it's related to this idea of the patient portal. I wonder if you can say something about that.
So I think the patient portal is going to be a vitally important piece of real estate, digital real estate, moving forward. I would actually think, we've been thinking of it sort of more broadly. The experience with patient portals, most places they've been implemented, is that it is a self-selected minority of patients that actually go use it. And perhaps those that need it the most, a patient portal, I should define my terms, is a way for the patient to access their health records, request appointments, refill medications, and sort of manage certain aspects of their health care. Unfortunately, what I've read of sort of early implementation of those things is that it's a self-selected, sort of the worried well that are the ones that engage with the portal the most, as opposed to those who might need it the most. So what we're actually thinking of doing in terms of our approach to the portal is we're adapting a broader view of thinking of more proactive programs that would do outreach via people's cell phones, mobile devices, other things, and tie that information back into the portal as hopefully to generate a site that has value for patients. So I think it's vitally important, but I think it needs to be a proactive thing, not a place for the worried well to go.
I think that's great. It leads me to my next question for you, which is related to tablets and phones and mobile devices and,
Right.
you know, doing more home monitoring, and how does that fit into this continuum?
Right. Well, I think it's absolutely important, and that's where, particularly with, you know, we could tap into the expertise in the audience. We really view ourselves as a group that has expertise in the creation of meaningful messages. We need information to then be processed to help us understand what messages to write. Most of our information has come from self-reported answers to survey questions, but the world is wide open in terms of the types of information that can be collected from home monitors, physiologic monitors, social networks, or other sorts of things. So that's particularly, you know, an area that we're interested in developing additional collaborations.
Yeah, Dan. Hello?
I'd like to pick up on that. Please. So, kind of two-part question. You know, we heard this morning about an elaborate project to instrument the ocean and to actually steer instrumentation by closing loops. The auto industry is actually making reasonably good progress on doing that for automobiles. So, where are we with respect to personalized medicine and kind of having real-time feedback from the human and then monitoring and processing that data and doing maybe, you know, interventions and so forth? I mean, and what are the barriers to doing more there? For example, I think there are things out now where you could read your blood pressure into your iPhone. Your iPhone could send it off to some database, and something over across the street here could be monitoring that and triggering intervention. But are there other billing barriers, compliance barriers? I mean, why can't we be doing that routinely now?
I'll take a first stab at it, then I think, Brian, you'll probably be able to answer better. One thing, it hasn't stopped the research per se, but does become a challenge in terms of implementation, is the system of financing and reimbursement currently does not support these types of activities, right? So if you're going to put these things in place, and we still think they have value, it's really important to understand what's the financial model for getting those implemented and carried out over time. I would argue you can do it, because these types of monitors can actually save in terms of expensive person power. So you can show that. But I think the other way of answering your question, there probably is a need for broader financial reform. And some of the work that Andrew talked about in terms of accountable care organizations, I think are going to move in that direction. In terms of answering some of your other questions, we'll start sort of macro and go more minor. So there are all the devices that you can see, hear, and hold, right? Scales, glucometers, blood pressure measures, those are all out there. My basic approach to those is they're all good, but they can all be made better. They refer to these devices as smart, but I don't think they're really smart right now, because what they do is they beep at you. Last time I was like needing to be motivated, a beep was not particularly motivating to me. So you can imagine a pill box that might beep if you don't take your medications. What we'd like to do is to have that pill box be able to tie into intelligent messaging that could remind you of what might your core values be, why you might want to manage your diabetes better, and give those types of reinforcement messages instead of just beeping at you. So it's...
But we can think beyond that.
Okay.
We can think about implantable things.
Right. And
yeah, and measuring the health of populations,
Right.
which is one of the goals of going back to
Right.
Andrew's slide, and
Both
meaningful
individual
use.
and population.
Right.
Yes, I mean, in 2015, we really have to have reports out to the government, CMS, and other
Right.
government agencies on how the health of our population is improving based on the meaningful use of the electronic health
Right.
records. It's written in the legislation. So part of what
So I
we're
guess
doing.
the bottom line question is, all this that we're doing across the street here, all these hundreds of millions we're spending,
Right.
anticipating the kind of real-time monitoring
I think that we are.
people live their day-to-day life.
Yeah, the two that I know about, and then Brian, please fill in the gaps. Is Dr. Najafi, right? Dr. Najafi and the WIMS Institute, and then Mark Burns. Is it Mark Burns, the chemical engineering? They're doing a lot of work with microsensors, and they at least the Micro Sensing Institute. There's sensors for inside the eye around glaucoma. I think people are developing sensors that actually implant inside tumors to measure initial response to therapy and let tailoring of chemotherapy. So I think people are developing in those areas. If that's sort of the direction you were thinking to go?
There's no question about it. It's just, you know, the talk this morning.
My question is partly, yeah, I know Mark Burns' work and I know all the nanotechnology.
But what about the sensor
And then
net?
the question is, are there these barriers, like we don't know how to charge for it, or we don't know how to handle it within HIPAA, or we don't have the right network
Oh.
connectivity?
And there is a movement out there. There's this mhealthy.org, if you check that one out. Deborah Estrin, who you probably know well from UCLA, and Ida Sim up at UCSF, who's a MD, PhD medical informatician, have joined forces and created this not-for-profit to be a clearinghouse of, you know, frankly, apps that could be put on these mobile devices that can seed up some of these sensor networks. And we're seeing a great deal of success in something called the PTSD Coach, which is an app that can be implemented on a mobile phone in folks who suffer from post-traumatic stress disorder, and their families can have this mobile app and could feed into the VA and the DoD electronic health record systems and collect a vision across the spectrum of PTSD sufferers, both you know, people who are still in the service and people from the National Guard Reserve that came in who are back in the community, and these kinds of things are taking off. So that's just one example. But I would say, and this is one thing, there was a call, HIPAA, you mentioned it, but
Right.
you'll notice we didn't say it, so there's something wrong there. I mean, that's a biggie. So I don't want to even go there. But one thing with personalized medicine and healthcare, and I'd love to hear what Larry has to say about this. You mentioned 23andMe,
Yeah.
but that's not the only one. There are several, you know, it's not going to be that we at the health system or any one hospital are going to have many of our own tests. There are going to be tests and advice and all kinds of things coming at us from all over. So the question is, the other thing that we didn't mention is personalized health record. That word wasn't mentioned.
Right.
So you can see that we're dealing with a whole panorama of change.
Yeah, so I think that's, you know, this debate, I just came back from Honduras over Thanksgiving, and there's a very interesting debate going on as they try to modernize their healthcare system. Should they try to build electronic health records that are clinic-based, or should they really build it around the patient in terms of personal health records? And so there's some very interesting conversations, particularly in the developing world, about what are the best strategies for trying to get you know, who's the center of the health information nexus, so to speak.
Okay, yeah. Chris.
So I think this is a little bit springboarding off of some of the discussions.
Here you go. Thank you.
Sure. So some of what you mentioned was, I guess my question is essentially, if you build it, will they come? We know, all the people here know we're going to get hit with this volume of information, and this information is potentially extraordinarily useful. But for individuals with different cultural backgrounds and different demographic values,
Right.
will they actually adopt this new wave of technology and information? And if they do, how can we help them? I mean, and I know that's your whole thing, but if we're seeing a diversity of services like 23andMe, how are they going to make an informed choice?
So I think that's a really big question. I'm not sure I have all the answers to that. What we do try to do in terms of, I think if anything, it will come to the issue of where is trust generated, right? So a lot of what you're talking about is who trusts what and why. And what we're finding, and this is from like Health Information National Trend Survey, other sorts of things, there was this thought way back when that as more and more health information became available, as people's trust in their physicians would go down. And in fact, I think we're seeing the opposite, as people are gaining more and more access to different kinds of health information. Rightly or wrongly, their trust in their physician is going up, right? I think what we can try to do is build tools that can help, you know, help guide or inform these conversations to help people find the information out there that's most relevant for them. I do think particularly for a portion of the population that's going to be the least advantaged and have the greatest needs, they won't come unless we build programs that are able to go out to them, that are going to reach them through their phones, that are going to reach them in other ways that they sort of value. And then if we're going to do that, we have to demonstrate value added. They have to perceive the value of what they're doing. Otherwise, we might get them once, but they're not going to stay with any sort of program.
This is not so much a question as a comment.
Okay.
My name's Patricia Anderson. I'm the Emerging Technologies Librarian for the Health Sciences.
Oh, we have to meet.
We have to talk.
Okay.
There's a huge community working on the area of mHealth apps, I'm sorry, mobile health apps. The healthcare social media community, I'm deeply engaged in those communities. There's work going on in the library system to support both the healthcare social media activities and the health outreach, health literacy, plain language movements on campus. There's an initiative from NLM to support the information prescription for those patients who need the extra help and support of directing them to a librarian who will hold their hand and talk them through it personally.
Sure.
And going beyond, there's
Absolutely.
There's all these resources to tap into to
Right.
support the type of work that you're talking about. I'm working with the Mayo Clinic Center for Social Media. I'm on their board. There's a team I'm working with, a couple of different teams I'm working with on campus who are doing research on social media adoption for healthcare outreach and interventions. There's a huge amount of stuff going on that we could be sharing on campus.
Great. Absolutely.
I want to encourage everybody to take a look at one site along these lines. Another area emerging is the patient advocacy community, social network. Just take a look at Patients Like Me as a link, little homework assignment. It is an absolutely fascinating community that's evolved around peer-to-peer. About 140,000 very active members around neurodegenerative diseases. There was a movie made out of the founding. It was an incredible, frankly, story. I've had a chance to meet those guys.
Did you see the research that Mayo just did based out of that, where they found an online patient care community for an extremely rare disease? At that time, the maximum population in a clinical trial on that disease was about 40. And by working through the social network, they were able to do a clinical trial remotely through distance connections of over 80 for this rare disease, doubled the size of the previous clinical trial. There's some amazing stuff going on.
It's a game changer. Like in cancer, you think cancer research is a big deal. We have trouble. We don't even get up to 5% of our patients coming into the clinics are participating in the research studies. Over half of the clinical research trials that we start don't accrue enough patients to go through. And this is a new way of that we can actually do a lot of good and support a lot of patients, and they share information. It's fantastic. Anything else? Any other questions? Andy? Yeah.
So as you look at where the center of all this is, how much, there's a lot of concern in the general population about as it's become institutionalized, sort of personal loss of the health record, particularly for privacy issues. I'm just sort of curious how the state of current privacy legislation is encouraging or discouraging in terms of people feeling willing to have this information kept centrally versus personally?
So there's a couple different ways to answer that question. I think the Patient Like Me site is a very interesting example to bring up when thinking about privacy issues. This is probably an oversimplification, but physicians and health system administrators are probably more concerned about privacy than patients themselves in most cases. And we are surprised at what patients are willing to share when they perceive there's a benefit. The important thing to have in building these platforms, my sense is to make sure you're absolutely transparent in terms of what is and isn't being shared, and to make sure that the patient and the individual whose information it is has that choice in terms of what information is shared. So that's relative to those sorts of things. There's the, anyways, that's my first answer, if that partially addresses your question.
Well, it's a large degree of generation, demography. You know, you can really draw a line, and the younger people are not having so much trouble sharing the information as the older generation. I mean, it's really, then there's a whole literature about, identifiability and things like that. Just in our own little area here. And Dan gave me a call last week about Amazon's potential offering to have a HIPAA secure, cloud service. And, we need these kinds of things. So there's indemnification issues. There's issues of, the institution, the payers and the pays, and also of course, the participants and patients. Catherine, we're getting the hook.
I want to thank all of you for coming today. This is the end. I wanted to give people enough time for the networking break, which happens from now until 3 o'clock. So we have about 20 minutes. There's more food out in the atrium. And Victoria Stodden, am I pronouncing it right? Oh, good. Who's right back there, will be presenting in Forum Hall starting at 3 o'clock. It will be about the reproducibility of data. And it should be a fantastic presentation, as I understand, because Dan has seen her speak before. So, and so has Brian. So,
I saw you through the TV set in the AAMC meeting.
so that session will be in Forum Hall, just down here, following the networking break, which is brought to you by Google. And following her talk will be a town hall. We encourage as many of you as possible to come attend as a way of giving us feedback about what we're doing and how the Office of Research Cyber Infrastructure can meet your needs going forward. So thank you very much again. Thank you.